So moving on to our second topic for today, which is CML from the laboratory. And it's a very great pleasure to firstly introduce Professor Lateef Salawu from Ile-Ife in Nigeria. Lateef is preceded by his reputation. He is a consultant hematologist and professor at Obafemi Awolowo University Teaching Hospital. Very well published, very much in demand. Lateef, welcome. It's a real pleasure to have you here. And our fourth and final expert today is another giant in the CML field, Professor Sue Branford, also from Adelaide in South Australia. Sue is head of the Leukemia Laboratory in the Department of Genetics and Molecular Pathology at South Australia Pathology, a National Health and Medical Research Council Fellow, and leads the International CML Genomics Alliance. Welcome, Sue. It's a real honor to have you here. Would you please share your slides with us, Lateef? And as you're doing that, I'll let the audience know that we'll run this session a little differently from the last one. Lateef will spend a few minutes identifying the key issues, problems, and unmet laboratory needs in Nigeria. And then he and Sue will take turns, I think, highlighting key issues and unmet needs and how they can be addressed. Hopefully, we can then open up to the audience for questions and discuss any issues relating to CML and the laboratory that you like. Please feel free to come forward with your comments or questions. Okay, Lateef, over to you.
Well, thank you very much. There's no doubt that the introduction of TKI have revolutionized the treatment of CML. And this has resulted in improved overall survival of patients with CML in chronic phase. However, for a patient to qualify to be on the medication, it is mandatory that facilities for the accurate detection of pH and BCR-ABL is available for the diagnosis and monitoring of response to treatment and detection of mutation if it occurs. So what are the challenges, the issues and challenges and unmet needs in Nigeria? First of all, although we have facilities to confirm Ile-Ife chromosome by standard karyotyping using bone marrow cells or BCR-ABL using peripheral blood, detection of these genetic abnormalities are used in the diagnosis and for the monitoring of the treatment response. So what are our challenges? Well, I'll say that in the beginning, the hospital does not have facility for either pH or BCR-ABL detection. So the pH detection had to be outsourced to a lecturer who had facilities for chromosomal analysis at a cost of 5,000 naira then, which at that time is about around $50. Later, the hospital employed a staff that was trained by the same lecturer to take over the detection of pH in patient sample in the newly created cytogenetic laboratory in our hospital. So, however, high cost of reagents, high failure rate of culture, and long turnaround time became a big problem for the detection of pH. So unfortunately, no other center in Nigeria then, whether public or private, has a reliable laboratory for cytogenetic analysis. Hence, the Ile-Ife chromosome detection has to be suspended in CML patients. However, we still have a way out. So we have to resort to sending patient sample to UK for BCR-ABL. So however, the laboratory can detect other chromosome abnormalities. Our own laboratory, though we don't do the pH then, but we can still detect some other chromosomal abnormalities. Again, for BCR-ABL transcript detection using real-time qPCR, we know it's the gold standard for both diagnosis and monitoring of CML patients. It is also sensitive enough for detecting residual disease in the long term, and even when the bone marrow is negative for pH chromosome. Now, the type of BCR-ABL transcript will also suggest response rate to TKI and prognosis in the patient. But what are challenges? In the beginning, as I said earlier, the hospital does not have facility for detecting BCR-ABL. So blood samples were usually shipped to Hammer Sister Hospital in UK. So this is at the cost for the patient. At that time, it was about around £50 per test, excluding the cost of courier services. Because of this, not many of our patients can afford the cost. Hence, there was a high default rate, particularly when PH test is no longer available. However, in 2013, Professor Carlo of the University of Milan came to our rescue by donating a standard qPCR machine and also trained 2 of our staff in the laboratory on its use. As of today, the hospital depends solely on molecular BCR-able detection for diagnosis and monitoring of our Nigerian patients on TKIs. The cost of transcript detection quantitation is about $70 per test now. But if it has to be done outside, it's about twice that amount in private laboratories. Despite the high cost, most of the laboratories only detect without quantification, with the patient having to pay for quantification on getting to our facility. And this has to be so because before doctors would refer their patient to us, some of them want to confirm that this is actually, they should be able to, this patient should be on TKI. If it is not possible, then they may not be able to detect, send a patient to us. And this is because the referring physician will have requested for BCR able to be sure that such patient will benefit from Gleevec before sending them to our facility. Some of the private laboratories provide inaccurate values. That's one of our problems that we have. Some of them will provide inaccurate value. For example, as low as 3% without patient being on any TKI. But a repeat in our laboratory gives as high as 30%. Sometimes the laboratory reports minor, less frequent transcripts, such as this, instead of the classical major E13 or E14 transcript. Again, this leads to repeat tests in our facilities at a cost to the patient. One other problem is that reporting result of BCR is usually done in percentage, not on international scale. So we do not report our test results in international scale, but in percentages. We do not have secondary reference material to do this. Another problem is the single access to TKI in Nigeria. Despite not paying for the TKI, the cost of investigation and translation to our facility is enormous on many of our patients who have to travel long distances to access TKI in our facility. Now, if you look at the map of Nigeria, now this is where our facility is. So patients will have to travel from far away, that's maybe as long as hundreds of kilometers. For example, this is Maiduguri in Nigeria, for example. You have patients from all these places having to travel down to this location. You have patients from, this is Sokoto State, for example, have to travel all the way from there to this facility. So also from the southern part of the country. So we have patients all over the country. And in fact, some of them may spend days, a minimum of 3 days before getting to our facility, because they will use a day to travel, the next day to see us in the clinic, and another day to travel back to their location. So these are some of the problems we have. Now, our hospital is the only hospital where patients with CML can access TKIs in Nigeria as of today. This has also created a strong impediment with the adherence to medication. And especially sometimes ration their medication. For example, if a patient is to come to the clinic and doesn't have money to transport him or herself to the hospital, he may have to start rationing the drug before you'll be able to get money to come to the hospital. Now, however, the MAX solution is currently exploring the possibility of externalizing the access of TKI in Nigeria by creating other sites. For now, the site has been identified, but now this is the nation's capital. A site has been identified at the National Hospital where people from the northern part of the country can access their TKI, but this has not come to fruition. For now, all patients in Nigeria will have to travel down to our facility here to access the TKI. So Poor adherence to therapy is the cause of treatment failure and development of resistance. Studies by one of our colleagues have shown that adherence to Gleevec in Nigerian patients is as low as 47% against 95% that is expected. Now, another problem is that of detecting resistance to TKI. Resistance to TKI could result from both BCR-ABL dependent and non-dependent mechanisms. Unfortunately, hospital does not have facility to detect mutation. The patient has to be done in a few private hospitals available in the country. Now, the cost of carrying out these tests in a few private laboratories in the country is rather prohibitive for some of our patients. So during the COVID-19 pandemic, we had to employ the services of courier company to deliver Gleevec to our patients after obtaining results from their blood count and plus from their local physician. This is to ensure an uninterrupted medication, hence avoid development of resistance to TKI. Now, on the issue of treatment-free remission, the cost of therapy, treatment-related side effects, and anxiety associated with lifelong needs to continue medication remain problematic for some patients, especially the younger ones. Therefore, opportunity to stop medication and still maintain remission after the condition of TKI will be an appealing to many of them. So, but the challenges are TFR will however require access to reliable PCR monitoring, monthly monitoring for the first year, followed by 6 weekly or 2 monthly monitoring for the second year, and 3 monthly thereafter. Although the idea of TFR is appealing to many of our patients, for the pilot study carried out recently, in which 63.6% are willing to participate. However, the cost of adhering strictly to the regime of testing will be prohibitive to some of our patients. For now, only 2 of our patients are currently on TFR. So, in conclusion, although the basic laboratory facilities for diagnosis and monitoring of patients with CMS are available, but at the cost of the patient, consumables, reagents are expensive and are not really available. However, collaboration with a private company in carbide diagnostic is on in the area of mutation analysis to reduce the cost for our patient. Although free TKI is available, however, monitoring is limited by the cost of monitoring with no insurance coverage for CML patients and poor adherence to drug. So thank you for listening.
Thanks, Lateef, for outlining those challenges. I'd like to jump in now with a few comments. You know, it's interesting that you have outlined some of the challenges that you have in terms of, firstly, not having standardized methods. And we certainly realized many years ago the importance of standardization. So you've outlined how if testing in your lab, you may get one result, testing in another lab generates a different result. And this can really complicate interpretation of the data. So, of course, there isn't standardization available currently, but perhaps this is something working with other labs that even your lab may be able to work towards. Many years ago, we had an international program where we were able to support conversion to an international reporting scale. So perhaps that's something that your lab could work towards. But I just also wanted to mention that even without standardization, if you can monitor in one lab that has a good quality system, reliable results, even without standardization to the international scale, this is certainly something that you can get an understanding of how well the patient is responding to treatment. So it looks like everybody has to have either a Philadelphia or a BCR-ABL at diagnosis in order to qualify for TKI. So a test after that time, you can compare to that original diagnosis sample, and that can give you some idea of how well the patient is responding. If we can think about the log reduction from the diagnosis value, This can be a really important consideration to determine how well your patient is going. Also, some of the other issues that were raised by Matilda earlier, where there are a lot of labs now that are adopting the gene expert system. So, I'd encourage, if possible, this is a really great system for labs if it can be introduced. It's a small instrument. It can be used for a multi-purpose instrument, not just for BCR-ABL. It can do TB testing, can do COVID testing. But there's a lot of work has gone into these systems where it's very easy to use, so you don't need a lot of skills, a lot of lab skills. It is standardized to the international scale. So, of course, we understand that these are not available to everyone. Some of the other things I think was also raised earlier, where there may be some possibility to outsource some testing, and I know Jerry Radich has been very much involved in this, where a spot of blood can be spotted onto some paper and just sent by standard mail to his lab. And I think he's encouraging other labs around the world to set this process up as well. And then they can extract RNA from the blood spot and test using the gene expert. So I think it sounds like this is the type of thing that could be explored in a number of countries in Africa where there is difficulty in access to molecular testing. I can see that Sammy has raised hand. Would you like to jump in now? Do you have a question?
So I speak on the gene expert. We have the gene expert, but the problem is the cartridges. We don't have fund to be buying cartridges. That's our problem.
Yeah, I believe the cartridges are probably around about the same cost as the real-time PCR, but if you can't get access to the cartridges, then yes, that is an issue.
And Sammy, if you'd like to join on this.
Thank you so much, Anna. Thank you, Professor Lateef. Actually, Professor Branford has already reflected on what I'm supposed to ask or comment. Basically, instead of major, some reports minor transcript, and some reports 3% pre-TKI, and when it was reported, it becomes 30%. I think this could be a legitimate result if the time is not really considered. Because sometimes in our case, by the way, I'm from Adelaide University, Pathology, so we come across the same results, but when it has been repeated, it means that after the patient has been longing, it's obvious that it will not provide the same result. But one important issue that has been addressed by Professor Branford is if the same laboratory is being utilized, then the consistency result can provide a very legitimate result. In addition to that, we have already published one paper. Professor Hook has already been mentioned in his review article. It's a multiplex PCR, which is very, very essentially established or used in low resource setting. So this is what I would say. Thank you so much.
Mm-hmm. And Emma, do you have a question?
Thank you very much. Hello, everyone. It was just to say that with the Gene Expect, we get our cartridges through Max Foundation. I must say that the Gene Expect machine that we have was through the efforts of ICMLF, Cepheid, and Max Foundation. So maybe it would be good to contact Max Foundation and see how best they can help you with regards to the cartridges. Thank you.
Yeah, I think that's a really good point. The Max Foundation have been extremely helpful. So if they could extend that help further, it sounds like there is quite a need for that. One of the other issues that I think has already been discussed, but it's the importance of, if you can't afford to do a test, what is the appropriate timing? And I think Tim's already mentioned this, of how important the 6-month time point is after starting TKI, because this is where, you know, in a lot of cases, if the BCR-ABL value has reduced significantly, it gives a lot of comfort to the patient and the clinician that the patients are on the right track and probably going to do well. And again, as Tim mentioned, if the BCR-ABL values are still high or there's been no change, then this is certainly a time that could be considered for a change of treatment. So Lateef, I don't know if you have any comments on that, whether you advise your patients exactly on what is the best time point if they can't afford testing. What is the best time point to at least have one test?
But actually, what we normally do, at least at the beginning, once the patient comes first, he or she has to do that test. And as people already said, after a year, you should also repeat the test, the BCR-ABL. Should repeat that test again. But the 2 patients that I mentioned that on TFR now, they have the money, they're able to do the test at least twice in a year for now.
Emma, looks like you have another question whilst we're...
I only to comment that in terms of testing among the patients, yes, it's difficult and sometimes they cannot afford, but I think that Tim's advocacy for us to talk about it now, TFR, is important. But most importantly is the education. Now, we also face challenges with financing, but now I think the message is getting through. So even when we are out of kits, we have patients demanding for kits. And so I think that the education is important. We should keep talking about it and also add the advantage of being able to have TFR. Thank you.
Can I just ask Lateef, how you said you've managed to have 2 patients go ahead with attempting treatment-free remission. How many patients do you have that come to see you? Do you have a sort of, I know we heard numbers from Matilda. What are your numbers like in Nigeria?
So for now, we have over 8,500.
8,500?
No, 1,500.
Oh, okay. Even so, that's an amazing collection of patients. And just 2 that have managed to get to TFR. Yeah, that's, we've got a long way to go.
Yeah. Yes, we do. I think the big challenge that, as he mentioned, when I was listing them down, if only we were looking at the cost of the medication, then that's different. But then you look at the patient's ability to come for the clinic, and that's why decentralization then helps, because the cost of travel becomes an issue, the issue of adherence, as he mentioned. Because it was interesting that in the study he mentioned that 63% of patients were willing to participate. So I think it just becomes an issue of looking at how to make the tests accessible, even cost-wise.
Yeah, I mean, it's a bit of a distorted situation. The drug is completely free, but the tests that would allow you to stop the drug are very, very expensive. So you get the situation where you've got 1,500 patients who are just going on and on and on with drug therapy. And you'd suspect if we could actually get PCR testing done, there might be 300 or 400 of those patients who would actually be able to stop and stay off therapy. So yeah, it's a huge challenge. And I don't have an easy solution, but it's something we're having some meetings with the Max Foundation next week when we're in India. So it's something I'll raise with them then, that if we can get some sort of balance between drug cost and PCR cost, we might be able to treat more rationally.
For sure. We might invite Dr. Rahman Bolarinwa and then Amabeni again, please. Dr. Rahman.
All right. Thank you very much. Thank you for allowing me to have a word here. As Professor Salawu mentioned, we actually have over 1,500 patients at Ile-Ife, assessing the TKIs. In the current study, alluded to by Professor Salawu, about doing assessing TFR in a patient. Actually, a total of about 32 patients, which are currently in deep molecular remission, were interviewed, were given questionnaire to really assess their interest in assessing TFR. So it is the percentage he mentioned out of these 32 that are willing to actually go on TFR. The other people that are not willing to go on TFR is as a result of the cost of doing routine medication in the monitoring of their TFR. That is the challenge to them. We actually have some of them who are willing to go on TFR, but we are trying to see how best they can assess their testing and ensure that the monitoring is actually done appropriately, before allowing them to start the study. Only two currently, as Prof mentioned, on TFR. One of them is on second generation TKI, whereas one is on imatinib, and the two of them are doing 6 monthly assessments of their molecular testing currently for now. One of the other problems, as Prof mentioned, is the issue of monitoring our patients for mutation screening. In one of the studies that we did some time ago, that was presented at Haltic, about 50% of our patients usually develop some form of mutation at a point in their TKI therapy. And it's been very challenging to really assess their mutation status and be able to know what second generation TKI will be most beneficial to them. A number of these were able to do this test outside, in private facilities at a very, very exorbitant cost. And this has been a great limitation, to most of our patients that are developing resistance. As mentioned by Prof, actually, adherence is one of the greatest challenges, of this patient in ensuring or in achieving a better outcome in terms of their clinical status, their level of mutation, their level of their response to therapy. Adherence has been an issue in them. So this is another great challenge for most of the patients, probably because of the distances and many of the patients that are closer to us, which we are able to see, come to clinic as at when due, tend to, be more adherent than those that are from far away. Most of them, probably by the time they go back to their different locations, they rarely go back to see their primary physician, except when they come around and we insisted that they must go and see their primary physician. That has been a great challenge, in the monitoring and management of most of our patients. Thank you.
Sue and Lateef, would you like to pick up on any of that?
Yes, it's interesting that there seems to be quite a high level of mutations. If 50% of the patients will get a mutation, so that's a really high level. And it may be related, as you mentioned, to the non-adherence. It means that the BCR-ABL cells are perhaps constantly rising and falling, and it's just sort of providing an environment for these mutations to occur, and then not being able to fully characterize them is problematic. But I guess this is the case for a lot of resistant patients, because we know that BCR-ABL mutations are only a problem in about half of the patients who have resistance. So there are a number of different resistance mechanisms. And in this case, I guess if you don't have the BCR-ABL kinase domain mutation testing, you have to go for the best TKI that is available for your patient based on comorbidities, etc. And certainly Tim may be able to comment on this as well. What do you do when you don't have full characterization of the resistance mechanism? Do you just have to go for the best TKI that you have?
Yeah, it's difficult. Oh, hang on. It's difficult when the best TKI at the moment in terms of resistance is ponatinib, and ponatinib does have a very difficult toxicity profile because of its vascular toxicity. We're getting better at using it, using the optic type strategy where you use it at full dose until the patient achieves a good response, and then you reduce the dose to 15 milligrams a day. Does seem to be a good strategy, and it does seem to greatly reduce the vascular events. So in a patient who had who was in the first year of therapy and had no response to imatinib and then no response to a second generation drug, I think you almost don't need, I mean, it'd be nice to have the mutation data, but in that patient, it's very appropriate if you can get it to get them onto full dose ponatinib and then reduce that dose as soon as they achieve response. But I don't know what the availability of ponatinib is like in the various countries around Africa. Can any of you comment on that?
So the challenge is ponatinib is sort of left as the last resort. So like what we do in the program, and our situation echoes what the person who's asking the question says, that we're not able to do mutation testing, $600. So we do blind switches based on comorbidities, and then sometimes either if it's bosulif. So most of the times our go-to is dasatinib or nilotinib, and then if they don't respond, that try bosulif, bosutinib. But when it's clear that they are not responding, we at least ask for a bone marrow. Why? So that we know whether they are in blast phase. If they are in blast phase, we switch them straight to ponatinib. Right. And then most of the time, very few patients have been able to have chemotherapy, treatment added to that. We just have one patient who is like on his second cycle of azacitidine with ponatinib, and then we're going to see if we can add venetoclax, but his AML. But as I think one of the things that we've that maybe would be something for discussion is maybe it's having grants or something, because in our team, what we noticed when there's a time Novartis used to give grants for testing, and then that would allow the hospital, the lab, one of the labs to reduce the price by half. And we had a higher uptake at that time. So I think looking out for opportunities like those that can increase the testing, and then seeing within the region, can we maybe, if any of it, do a project that looks at those mutations? Because I think also understanding our disease is important, because we've noticed you have a few patients who are young, but they lose their molecular response very quickly and get aggressive disease and just keep changing. And but majority of the patients are okay. So you tend to think like with those patients there must be something different about their molecular milieu or presentation at that time.
So I can sense collaborations coming on there. I wonder, I'm seeing lots of hands. Tim, I will let you respond, but there are lots of hands, which is very exciting. We'll go Amma, and then Alcatel and Ahlam after Tim responds.
Just quickly, I mean, it's very sad that you have to wait till the patient's in blast crisis before you can get ponatinib, because it's largely palliative in blast crisis, whereas it can be very, very effective in patients who have developed resistance to several TKIs. It's a shame that they make you go through every single other tyrosine kinase, even though we know that using bosutinib after having failed nilotinib and dasatinib is pretty futile. I wonder whose policy that is and whether we can move that to allow the ponatinib to come in earlier, because once it's last crisis, as you know, you've missed your chance really of controlling the disease.
Emma.
I just wanted to say that some years back, TFR in our part of the world was almost impossible. But I think things are becoming clearer in terms of the criteria, and I think we are going to get more numbers. The other thing about TFR is that sometimes the patients themselves don't want it. I think there's that fear that if there's a chance of the disease coming back, there's a chance of the disease coming back, they don't want to go there. But I think that in terms of TFR, things are looking better in our part of the world. Of course, the adage about monitoring is very important. So that will be a challenge in TFR in this community. I currently have a patient who is doing quite well. There were 2 others who I recommended, but again, they were reluctant because they are afraid that if the disease comes back, it will not be controlled. Thank you.
Thank you. We might ask Alcatel and then Ahlam, and I can see Simeon's there as well. This always happens within the last 2 minutes. Everyone comes to ask a question. Dr. Nasser, please. You've been waiting a while.
Hi, good afternoon, everyone. So I'm Ahlam Nasser from Tanzania. I have comments and a question. So I do echo on regards to challenges related to setting molecular testing in African countries. Maybe as to share a bit as a model, what we have done to establish the BCR-ABL in our region is that we started as a research project, and then we moved on into setting the logistics as part of the research project, and thereafter making a case to the hospital that is an obvious demand, and that if we do work with the Marx Foundation, the CEFED and Marx Foundation in collaboration, because they have preferential prices for low middle income countries, which are very favorable for the cartridges. So what we have done after making the case to the hospital, according to the obvious demand, we did reduce the cost to the patient through cost sharing. I'm not sure whether that mechanism is the same as Kenya, what they've done, because the test does seem remarkably lower, similar to ours. So we did write a paper for that, trying to establish diagnostic capacity, setting up comprehensive care for CML. I think it might be, I'll share with Eileen if it will be interest for other countries if they would like to look at similar model. So regarding with mutation, similarly, we are trying to use the same model. We are currently doing mutation testing, and this as a part of research project. Hopefully moving forward, being able to establish regionally and through Sub-Saharan Africa as a service. But what we have done differently is that with mutation testing, majority are done through NGS, like Illumina panel, which sometimes can be very costly in terms of sustainability. So we are doing the testing through nanopore sequencing, hoping that because after we have considered the cost for sustainability, we think that through a technology such nanopore, we are likely able to reduce the cost. So far, we are not sure how much that is going to cost as a service, but I do want to welcome collaboration, regional collaborations. Maybe we can apply for a bigger grant and work with our colleagues in other African countries to make sure we have that test as well. So in terms of a question, I wanted to pose this question to Matilda regarding the changing of TKIs as dasatinib as their second preferred. What are the rates of cytopenias do you see? because from our setting, we see quite significant cytopenias with our patients. Even on imatinib, we have frequent cytopenias that requires treatment interruptions. So I'm not sure the frequency of cytopenias from their side, both imatinib and dasatinib. Dasatinib is very notorious in our setting for causing cytopenias, and we do try to avoid that. We are more likely to go to nilotinib unless if the patient is not responding, then we do consider dasatinib. So maybe just to get their perspective from their end. Thank you.
Yes. Well, thank you very much for those good comments and the opportunity there for collaboration. With regard to cytopenias, we do see quite a bit of cytopenias. There's actually a paper that has been written by one of our colleagues, and it's free to access, cytopenias in CML in Kenya. And we don't see that much with dasatinib. In fact, sometimes what we tend to do, which again becomes a challenge in the absence of monitoring, is you end up doing a dose reduction. And during our World CML Day, we actually presented a case like that of a patient who has TKI hypersensitivity. And she had it with imatinib and even nilotinib. So we've not seen a lot with the dasatinib, more with imatinib. In terms of switching to the switching options, it's also an issue of access. Like at the moment, the dasatinib slots are full. So we can't, I wanted to switch a patient to dasatinib, but I had to look at the other options. Nilotinib is, because it's available in the country, the patients have to use their insurance. So if a patient has insurance, then they would access nilotinib that way. And then bosutinib, depending on the patient, we have many of them having issues with the 500 milligrams. So because of the diarrhea from it, so you find most patients are either on 300 or 400 milligrams. But the issue of cytopenias you raise is very, very true, very valid in young patients. And most of these patients, we find, even if when you look at their disease, it's not that they are in failure. It's not that it's a genuine, you do a bone marrow and the bone marrow report you get is hypocellular marrow due to the treatment. So maybe that aspect of, I wonder whether there is a subset of our patients who are more sensitive because the study didn't really, it was more general looking at cytopenias, but in practice, we've seen more with imatinib than dasatinib.
And I hate to do this when the discussion really gets going, but we are so close to being out of time. Can I have some last comments, please, from Professor Lateef and Professor Sue from the laboratory, please?
I just like to congratulate Dr. Nasser for that excellent suggestion of collaboration. And it looks like from the chat, there are a lot of groups who are very happy to collaborate. So I think that's a fantastic idea to get things moving. And starting off in a research setting is exactly how we started as well. So hopefully this can move more into the diagnostic setting.
Lateef, do we have a last comment from you?
Yes, on the issue of mutation that was talked about has been very high, almost 50%. Well, in our own situation, I think the reason is not far-fetched. As I mentioned in my presentation, some of our patients, once they cannot access or they cannot come to the clinic, they start rationing their drugs. So, and that may be part of it. Some of them may not even come at all until later when they're able to source for funds to come to the hospital. So I think that may be part of what is causing our own in our own case. Thank you very much.
Thank you. Thank you so much. That last hour and a half just completely disappeared. I'm so sorry, Emma. I'm sorry, Simeon. Please send your question directly to me and I will get a response back to you. We've just out of time. Thank you so much, Professor Sue and Professor Lateef, for such a lively discussion, and to all the audience members for getting involved and for your questions and comments. Again, if you have something which hasn't been answered, email me. I'll get you a response. So we hope to see you again soon. The second scheduled African discussion will take place on Wednesday, the 29th of November, same time as today. And as you can see, the topics are treating CML in children and young people and the impact of CML on pregnancy and fertility. And there's such a great team of experts leading those discussions. The third discussion is scheduled for Wednesday, 27 September, where the topic is the rather wide-ranging challenging scenarios in CML. Again, a fantastic team lined up to lead us on that. Please join us. I'll email you links shortly. And we hope to see you online too. If you aren't already familiar with the ICMLF Knowledge Center, I'd strongly suggest that you check it out. There is quite literally a wealth of knowledge in there with dedicated modules on TFR from the laboratory. The list goes on. We add to it all the time and update it. So even if you think you've been there and you see it, please drop back in. We add to it all the time. If you want to keep up to date with what's new in CML, please check out our website. Sign up for the ICMLF newsletter, and we will send you papers of the month, keep you up to date about upcoming meetings, webinars, links to summaries, conferences, and discussions. Also on the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to the key experts in the field for advice or for commentary. It's a great resource for you all. Please use it. Or you might like to join our social media outlets, Facebook, Instagram, Twitter, whichever of those you prefer to engage with. Okay, that's it from me. Thank you very much for being a part of this first ICMLF African regional discussion. It's been great preparing for it. I'm so glad we finally made it happen. And thank you all so much. We'll see you again soon.